many a times diet cannot be of healing in that particular disease. Many a time diet is just a part of the uh, palliative care. Sometimes it is a part of the reinforcement process. Like, for example, in this case, I was indicating two kinds of things. One, these osteolytic lesions could be, since the ESR is rare, it could be in a form of some kind of bone metastasis. Secondly, I was saying this could be indicative of various diseases like the Paget's disease. Now, if it is the Paget's disease, what exactly do we know about it? This is basically, as you, if you remember what had been discussed earlier in your class, we had discussed Paget's disease in details. There, it is usually a disease which affects your pelvic bones, your skull bones, your spines, your legs. These, I'm not saying that it doesn't affect your other bones, but these are the major bones where you find these osteolytic lesions. And over time, what happens? The bone becomes soft, or you can say they become fragile, they become brittle, and that is going to lead to fractures. And alongside, there would be, a further swelling of the affected areas. There can be involvements of the tissues around the affected areas. And as I was saying, as I was pointing out, that this can also be a part of some kind of a osteosarcoma, which is not yet detected. It is not given in the case. The case doesn't ideally indicate to Paget's. Now it does it ideally indicates to osteosarcoma. So unless and until there is a more detailed CT report available, we won't be able to comment on that. So what we can do is we can assist, or we can provide the palliative care which would help in the remodeling of the bones. Now, there are certain nutrients. Of course, we all know that potassium and calcium, phosphorus and calcium are involved in the remodeling process. And alongside, what do we know? We know that vitamin D and vitamin K are also important nutrients which helps in the bone remodeling process. Here, one thing you have to note of concern, this is something which we must take into account. A 60-year-old male patient, before you're giving vitamin K, we need to find out whether this person is on any kind of blood thinners. Okay, so this is something that we take into account any time before we suggest mega doses of vitamin K to anybody. Okay, this should be a habit of ours to see from the medical records whether the patient is on any kind of blood thinners. Alongside, when you are suggesting mega doses of vitamin D to a patient, please be wary of the situation that mega doses of vitamin D could lead to soft tissue calcifications if not done with caution. Calcium supplementation and vitamin D supplementation together can lead to soft tissue calcifications. So, ideally, if there is such a scenario, we need to take into account of what is happening, or we need to take into account that the patient needs to be monitored very closely. So, could anyone quickly state what would be the another thing? Creatinine. The creatinine is slightly raised out here. 3.5 is not extremely alarming, yet it is not something that you do not take into reckon. This patient requires monitoring over time to see whether the creatinine ratio is being maintained around 1.7 to say 4, or whether there is an gradual elevation of the creatinine level. One thing which is one point which is missing in this particular thing is, I would always, if see a patient with creatinine 3.5, I would also want to check on the urea and the blood urea nitrogen, the BUN report and the urea report of the patient, which is not mentioned in this scenario. And ask, write down in the file, the patient's file, requesting for a BUN to be done, and also request for the reports of urea. Am I clear so far? Is there anything incomprehensible of till what I said about what I discussed so far? Have I been clear to everyone so far? Kanchan, okay. Anybody wants it repeated in Bengali? Somebody out here was not very conversant in English. Uh, that she wanted repeated in Bengali, the entire thing? Yes, ma'am, to what? Okay, no, okay, ma'am. Okay, fine. Okay. Then we are, okay, I'm getting yes, ma'am, and no, ma'am. Yes, to, okay, yes, ma'am, clear. Okay, thank you, Shukriya. So can somebody unmute themselves and suggest what would be the dietary plan of this? This is a very generalized dietary plan. As I said, had it been pageants, there also we wouldn't have been able to do much with the diet. If this is ultimately leading to osteosarcoma, we would not be able to do much with diet. So both ways, and other than what I've already discussed in previous classes about giving them nutrients which are easily assimilable or easily absorbable. That is your key point of diet out here. Giving them diets which are easily assimilable or easily absorbable. One point of caution, there is absolutely no call out here to give plant I'm sorry, not plant stenols, phytoestrogens. Absolutely no call out here to use phytoestrogens because it is often habit amongst the nutritionist community to use phytoestrogens, and even though phytoestrogens have been restricted to the female treatment, it is often used in males as well to arguably improve upon the bone calcium absorption scenario. But remember, out here, phytoestrogen is not going to be of much use. So we need to actually steer clear of soya proteins and soya isoflavones, which will not be of much assistance in this particular case scenario. So could somebody please unmute them and volunteer to suggest a dietary plan? Anybody? You needn't be like, yeah, you can be wrong, that's okay. We are all wrong at some point of time. I'm here to help you correct it. Somebody is mentioning high quality protein rich diet. We have a creatinine situation here. So a very high quality protein rich diet can actually worsen that. It can increase the renal load. That is something that you need to bear in mind. So it is not going to be a protein rich diet, though of course high quality protein is something I completely agree to, but it need not be a protein rich diet. So somebody would like to continue from there and add on to what Aruma just said.
Cheese may be given, ma'am.
Cheese. Let's not get into the items of the diet right now. Let's go into the general dietary principles. Let's first discuss the macro and the micronutrients, and then we can get into any particular items on the food list.
Okay, ma'am. Clear.
First, let's
Ma'am,
discuss the macro and the micronutrients.
we will do strict fluid restriction because of severe
I said you
hypercalcemia.
come on. Okay, Kamran, could you be a little more clear? I don't think we are able to get you completely clearly because of your network issue, I believe. So if you could be a little slower and speak a little slow because I believe there is static in your network. In your network.
Okay. Ma'am, first of all, we will do a strict restriction because there is severe hypercalcemia and
You restrict what?
fluid restriction, ma'am.
Fluid restriction. No, Kamran,
Just because
I
there
don't
is
think
severe
you require
hypercalcemia.
a gross fluid. No, Kamran, you don't need gross fluid restriction out here. You don't probably overzealously flee too much of fluid, but considering an Indian scenario, including whatever that you can add around another 300 loss, and that could be your total fluid allowance. Currently, till the creatinine situation
And ma'am,
worsens.
And in my opinion, this
Yeah,
is
Kamal,
this
go
is
ahead.
multiple myeloma rather osteosarcoma because all the symptoms are matching with multiple myeloma, and there is difference
Multiple
between
myeloma.
yes, ma'am.
Did you really is a multiple myeloma in
Because
this
there is
case? Wouldn't we rather see? Yes, it can be multiple myeloma, but the probability not this thought. I believe that this was being thought it was being thought as a Paget's disease, but I do not want to restrict the discussion only to Paget's disease. That's the reason I brought in osteosarcoma. But multiple myeloma, don't you be having more features if there is multiple myeloma in this case?
yes, because
And
there
the
is
other yes, yes, Kamran. Let's continue with the discussion. And if somebody else would also want to contribute, please do so. See, can you? I personally don't feel that we should be dragging this up till multiple myeloma. We would be needing certain other features before we could, think about multiple myeloma in this case. So, would
yes,
anybody
ma'am.
want
Because
to contribute?
can I
I'm
explain,
not
ma'am?
completely disagreeing to what Kamran is saying. But then, if we are talking about multiple myeloma,
Yes,
then there would be additional features. Could somebody point them out, please?
yes. Features are generalized bone pain. This is a very common symptom of multiple myeloma.
Generalized bone
And
pain
second
should
thing
not be generalized bone pain should not be immediately associated with multiple myeloma. See, basically, had it been
yes,
multiple myeloma, one of the key features, if you remember, this was told to you in your I don't know whether you people did your orthopedic class, but do you remember about this oil droplet appearance that was mentioned in the slides?
because
In
the
the
second
reading
thing is
features, you will see this
second
oil
thing is
droplet
serum globulin level,
appearances.
which is much higher than a
Kamran,
normal. Second thing is not serum globulin, which is 7 mg per day, which is not commonly seen in osteosarcoma. And multiple myeloma is related is
what level?
globulin,
I couldn't get what level.
serum globulin protein.
Serum globulin level is also elevated in Paget's disease. So why do you not think that this is Paget's and why do you think it's because, you don't see osteolytic lesions of the bone, you actually see oil drop appearances on the thing for multiple myeloma. That is one of the most
Yeah,
common
which is one of the common features of multiple myeloma. And the third most common feature is serum calcium, which is pretty much high, 17 mg per
yes, but
day.
then what distinguishes it from Paget's? Why don't you accept it to be Paget's and why do you call it
Because I mean, Paget's disease, serum globulin not elevated
no, no,
commonly,
no, that's no problem.
and
It is elevated, and besides alkaline phosphatase, what we are missing out here is the alkaline phosphatase value. We would probably have asked for an alkaline phosphatase value out here before we could actually comment whether it is an osteosarcoma, it is a myeloma, it is a Paget's disease. Because in Paget's disease, alkaline phosphatase levels normally shoot up. Okay. Hello. Am I audible to everyone?
Yes, ma'am,
yes,
clear.
ma'am.
Yeah. No, but Kamran, please continue because you were leading a discussion. You were leading the discussion on a very proper note. So let's.
Yes, ma'am. Then before
Kamran,
making a right, we must be confirmed with the diagnosis because diet for multiple myeloma and diet for osteosarcoma is quite
I
different.
think we also need to think about whether there is parathyroidism. That can also be a cause because see the calcium is elevated.
Yeah.
So this is basically what I was trying to point out here, and Kamran has come up. See, there are so many additional things that also Kamran could point out here. So basically, that is the reason why I was stating at the very first, in when I started on with this discussion, that we do not have adequate clinical or biochemical parameters given to us in this diet in this question to pinpoint any particular diet. So we have myelomas, we have osteosarcomas, we have Paget's. Now seeing the calcium level, I pointed out it can be a parathyroidism. Okay. So basically, I want you to initially give a very generic diet in this situation, which can, fit into all of these and suggest the various other parameters to be checked. So what are the other parameters we had out? Kamran mentioned myeloma. So if you remember, you would be needing radiological findings for oil drop appearances of the in the skulls. I mentioned parathyroidism, so the PTH level I need the PTH level monitored. There's a creatinine elevation, so without even associating it to any further disease, we would need a BUN and a blood urea level. There might be Paget's disease where we'll find an associated elevation of alkaline phosphatase, a huge elevation of alkaline phosphatase. So we would just not request for alkaline phosphatase check, we would ask for a complete LFT. And could anybody other than Kamran please tell me, Kamran, don't answer all the questions. Other than Kamran, tell me quickly what are the various tests which are there as the package of LFT? Somebody please unmute themselves and volunteer to answer. What are the other tests which are included in LFT?
SGOT, SGPT, alkaline phosphatates, serum bilirubin, conjugated bilirubin, unconjugated bilirubin, etc. are included in ALFT test.
Okay, and can now somebody tell me what are the new names used for SGOT and SGPT other than Shukriyo? Somebody please tell us what are the new names
AFT
of
and
SGOT. Kamran,
AFT
don't
and
answer.
ALT.
Kamran, don't answer. Let the others also need to perk up. It is always you, Ruma, and Shukriyo who volunteers for answers. Let please others also need to participate in the discussion. I believe you have other phones in your home. You can Google and tell us the answer. But everybody needs to be. For the last 2 days, I've been noting it's only Ruma, Shukriyo, and Kamran who volunteers. You can be right, you can be wrong. It doesn't make a difference. It's just a very in-house discussion. So please try and volunteer. Please try and talk up. After you repeat, you're correct, but your voice is muffled. Okay, now I need somebody. ASL and AST. Could you give us the full forms, please? Could you give us the full forms, please?
Aminotransferase and alanine aminotransferase.
Alanine aminotransferase, yes, that's correct. And the other one?
Aminotransferase.
I am not getting the answers. One was
Aspartate aminotransferase.
aspartate transaminase. Aspartate transaminase.
Okay.
Aspartate transaminase. And what's the other one? Somebody had said that correctly. AST is aspartate transaminase. And what's ALT? Alanine aminotransferase. Somebody just give us the answer. Now you guys really need to perk up during our discussion. You just can't be, switching on your sets and falling off to sleep or be busy in other works. This is normally a 1.5 hour discussion and I need everybody to complete attention. This is basically for your good. I really don't need an update on what's AST and AST. When somebody is contributing, please note it down. You are all in your final years, you are going to be becoming practicing dietitians in some periods of time, and it's not nice to be talking about very, very basic stuff which you are getting wrong. It really saddens me. Please don't do so. Okay? Okay. Let's get back to the diet form. So somebody had mentioned high quality protein rich. So I had objected to the protein rich part of it only because there was this creatinine and I believe the high quality stuff, high quality protein is perfectly correct. What else do you need to be cautious about there? And what does Ruma mean? Ruma had said this high quality protein. So what do we mean by high quality protein? Can somebody else contribute to that? There, see, because Kamran, Supriya, and Numa is not answering to us. Okay, whey protein, that's very nice. Yes, Tanya, I completely accept whey protein, but there is one problem with using whey protein. This calcium level, which Kamran had been concerned about, and which is actually very important. Uh, we have a 17 mg per deciliter of serum calcium. So, if you're trying to use a whey protein in the form of milk and milk products, will that lead to calcium absorptive food? What exactly is that? I've never heard of anything known as calcium absorb. Tofu. I just said we have to steer clear from soya proteins. So tofu is basically soya protein. You just cannot give soya protein to this patient. Chicken breast. Why not chicken? I mean, why are you going into the you next you come up with chicken ham, chicken bacon? No, no, no. Let's not discuss the breast, the cut of the meat. We are not interested in the cut of the meat out here. Please think clinical and please don't think in the form of recipes. Please think clinical. What about chicken? What's all this about chicken breast and chicken leg pieces and drumsticks and hams and bacons? No. By the way, while we're on the topic, does anybody know what is ham and what is bacon? Can you? What exactly is ham and bacon? There. You are allowed to Google if you want to and give me the answer. Animal proteins, okay, pork belly. No, it's not just the pork belly. Ham and bacon is basically particular cuts of meat. It can be a pig cut, it can be a chicken cut, it can be a turkey cut, it can be a beef cut. Ham and bacons are basically two cuts of meat from different parts of our animal's body. So, which part is ham and which part is bacon? Leg piece of meat, absolutely correct. The thigh part of the meat is termed as what? The thigh part is ham. Very correct. Very absolutely correct. And bacon? Could somebody tell us what bacon is? Can somebody kindly tell us what bacon is? It's not just pork, my dear. I just mentioned that bacon can be of anything. It can be a cut of it can be a cut of meat from an animal, and that animal can be any animal. See, basically, somebody was bacon is belly. Yes, right. Bacon is belly. It can be the belly part, basically, which will have less amount of fat in it. That is basically a bacon. Now, normally we stick to when we think about bacon, we normally think about a pork, but that can also include beef. That would also include chicken bacon. So, though normally chicken does not have much of meat around its belly, so it's difficult to cut out that piece. So basically, it is from larger animals. It can be lamb, it can be beef, it can be mutton or goat, it can be pig, as you've been all pointing out. So anyway, that was a little away from the topic, but since this had been raised, I just wanted to clarify it. So we would need to stick to whey proteins, but now yes, I completely agree to the fact that we would be giving whey proteins, but not as a whole milk products because we are not sure about the calcium level is already elevated and we do not want further absorption of calcium. Though one must remember that for the absorption of calcium, there are a requirement of certain other things. Can somebody tell me what interferes with calcium absorption, what nutrient interferes with calcium absorption, and what nutrient augments calcium absorption? Phosphate interferes with calcium absorption, vitamin D, I mean, which one? I would want to say which nutrient interferes with calcium absorption? Phosphate increases calcium absorption, okay. What other macronutrient would increase calcium absorption? Thank you for joining our class, Dr. Dutta. But please stay out of it. What is vitamin? Which D? Okay, that's vitamin D. Vitamin D, yes, but I am talking about macronutrient other than phosphate, and vitamin D is not a macronutrient. Whoever answered first class proteins, that was the answer I was looking for. Yes. What does iron do, Srilekha? Does it hinder or does it? No, nothing like seafood. Seafood has no role to play here. No, I'm not taking a class now. You're going to take a discussion there, please. Iron decreases. Now, anything else that decreases? Anything else that decreases food absorption? Calcium absorption? Iron decreases the absorption of calcium. Absolutely correct. Anything else? Tea, coffee. What basically? What is the factors of tea and coffee which decreases calcium absorption? Though we don't actually need to decrease calcium absorption out here.
Caffeine, caffeine.
No. Caffeine is not actually responsible for the hindrance of calcium absorption. What actually is responsible for the hindrance of calcium absorption?
Vitamin C, vitamin C. Vitamin C.
Hinders calcium absorption? No, that's completely incorrect. Tannic acid, yes, Roma is absolutely correct out here. It is the phytates and the tannates, the various phytates and the tannate salts which are present in tea, coffee, green coffee, various kinds of fiber-containing foods, phytates, yes, you are correct, which would interfere in the calcium absorption. So, see, that is more or less the general dietary plan for this patient. Has everybody got a general idea then? Oxalate, yes, but you know one thing about oxalate does interfere in calcium absorption, very correct. But if there is addition of certain, what you need to be more worried about is if there's calcium absorption and there is an increased oxalate synthesis in the body. Can anybody tell me which pathways of the body would increase oxalate synthesis? Which are the pathways in the body, metabolic pathways in the body, which would increase oxalate synthesis? Okay, that is something I will not be telling you. Beta oxidation increases oxalate. What does beta oxidation relate to? This is absolutely incorrect. What does beta oxidation relate to? From where do which oxidation will release a 2 coenzyme A with each cycle, each rotation of the cycle?
HMP pathway, ma'am.
If I talk about releasing of beta coenzymes A, you would first think about HMP pathway, or would you rather think about fatty acid oxidation? Long chain fatty acid oxidation, which is basically beta oxidation. For long chain fatty acids, for every 2 carbons, there would be the synthesis of 2 coenzyme A's, which enters your TCA cycle. Okay?
Yes, ma'am.
I would request all of you to go through your basic biochemistry once, okay, after this session, just quickly, because if you do that, you'll remember it for a long time. Lipid peroxidation pathway. Lipid peroxidation pathway increases your oxalic acid metabolism. I want you to find out what are the processes which increases oxalic acid synthesis in the body. Okay, and next day we do it, you give me an answer to that. Okay, so have we more or less been clear on the dietary planning of this particular patient?
Generalized dietary plan along with vitamin K and vitamin D3 enriched dietary plan suggested for that aforesaid patient.
So how do you plan to increase vitamin D3? See, we cannot use milk products. Basically, the source of vitamin D3 is animal products, right? So we cannot include milk products. So can somebody else other than Shukri probably spoke, which can help us in increasing vitamin D3? Actually, somebody was texting the answer, but at that point of time, just skimmed over it, but somebody has been suggesting something on the lines, which can be a good source of vitamin D3 as well as a particular precursor of essential fatty acids or particular precursors of prostaglandins and prostacyclins actually. Somebody had mentioned that. It was somebody had typed in that answer. Fortified cereals. No, somebody had given the answer and now you're coming up with lots of things which I won't say most. Yes, this is the answer I was looking for. Fish liver oil, basically deep sea fish oil. Okay, that would give you, that will be a good source of cod liver oil. Yes, Kamran is absolutely correct out here. Basically, think deep sea fish oil, which would have a good source of, somebody had mentioned omega-3 fatty acids as well as vitamin D. Shukriyo had already led us to the discussion where he said how vitamin D3 is important. And since I have already been talking that milk cannot be used, so it is basically deep sea fish oil, cod liver oil, as Kamran mentioned, which is going to provide us with D3. And somebody also mentioned tuna. Now, see, the thing is, once you're thinking about foods like tuna, etc., please be a little wary of the creatinine level. Okay. And secondly, find out whether the socioeconomic condition of the patient allows him to have such expensive food. Because in the hospital setting, per se, in our countries, even in very expensive hospitals, you will not find tuna being served to the patient. So that is something you need to be cautious about. This you might suggest tuna to the patient if the creatinine level seems to be lowering itself. Otherwise, don't do that. Stick to various fish deep sea liver oils at Shukriyo and Kamran suggested. Okay, and Uma suggested. So are we done with this question? Is there anybody who has any further inputs or anything that they need clarified about the question? Ma'am, we must be conscious about the vitamin D because we give unnecessary. I just need the, wait a sec. What was that? That was typed in corruption. Turn on report problem. Okay, just what was, we must be conscious about the vitamin D because if we give unnecessary, it will further raise serum calcium, which is necessary. Very good, yes. Kamran has been very right. We must be cautious, and do remember that the consultant physician would also be prescribing some forms of vitamin D and vitamin K. So you first need to find out whether his medical prescription has already inclusion of vitamin D and vitamin K, which is very likely in this case, and then you plan it out. So I would once again suggest the deep sea oil, liver oil, would be a good option because neither does it provide with too much of vitamin D. It is also a good source of omega-3 fatty acids and omega to a certain level omega-6 fatty acids, and alongside it provides you with other forms of EPA and DHA, which might be good for bone remodeling. Fortified cereals, okay, yes, but please remember to remove cereals. We don't want too much of bran for this patient. Okay, his ESR is high, so right at the moment is some kind of toxicity throughout his body. We want easily assimilable food. So fortification of cereal is fine, but what exactly does Pooja? What exactly do you want to fortify the cereals with? No, legumes should not be used. The creatinine level is pretty high out here, Numa. So we do not want to remove. You are the one who answered first class good quality protein. So legumes should be removed from that. No second class proteins for this patient at the moment. Okay. Could I please? Cornflakes. Cornflakes is fortified cereals. Bran. I don't want bran for this patient. What fortified cereals are you looking for out here? Somebody mentioned fortified cereals. What do you want to fortify your cereal out here? If you're planning to fortify it with vitamin D, Kamran very correctly pointed out that too much of vitamin D is going to be having a uh, harmful manifestation in this patient. So we really don't want to have fortified cereals out there. Okay, don't just use words. Think about it before you say. We do not want fortified cereals in this case. It's not required. Is that okay? Whoever had mentioned fortified cereals? Okay, Pooja. Then, ma'am, please, hydration for this patient, because hydration is a primary management for hypercalcemia. Yes, but Kamran, you remember we mentioned the point of hydration and we said that since the creatinine level is high and we do not have the other renal functional parameters, we would be taking the urine output and adding 300 ml to the to that to come to the input amount. So overhydration of this patient can pose threat. We would not do so immediately. Yes, please don't repeat what I've already said. Ban has already been suggested. We've discussed those points. If you want to add any other point to it or you have not understood something, otherwise we'll move on to the next question. অরেঞ্জ জুস দেওয়া যাবে? অরেঞ্জ জুসের অ্যাকচুয়ালি দরকার নেই রে, কারণ অরেঞ্জ জুস হলে না, অরেঞ্জ জুস ভিটামিন সি অ্যাকচুয়ালি ইনক্রিজেস দ্য অক্সালিক অ্যাসিড মেটাবলিজম, ঠিক আছে? তবে ক্যালসিয়াম একই বেড়ে আছে, এরপর যদি অক্সালিক অ্যাসিড মেটাবলিজম বেড়ে যায় তাহলে সফট টিস্যু ক্যালসিফিকেশন হবে। সো we rather keep vitamin C away from this patient's diet. খুব একটা বেশি ভিটামিন সি এখানে না দেওয়াই ভালো।
বার্ন টেস্টের পাশাপাশি ইজিএফআর এস্টিমেটেড জিএফআরটাও একবার অ্যাসেস করে নেওয়া যেতে পারে পেশেন্টকে।
এস্টিমেটেড জিএফআর এর কথা যদি বলো, তোমাদের দিস ইজ আ কোয়েশ্চেন, আমি জিএফআর আমি তোমাদের বলে দেব না। দেয়ার আর টু ওয়েজ দ্যাট ইউ ক্যান ক্যালকুলেট জিএফআর, মানে অঙ্ক করে বার করা যায়, ঠিক আছে? সো যদি আমার কাছে সেরাম ক্রিয়াটিনিন লেভেল থাকে, পেশেন্টের বয়স থাকে, যেটা আমার এক্ষেত্রে দুটোই আছে, অ্যান্ড পেশেন্টটা মেল না ফিমেল আমি জানি, পেশেন্টটা ব্ল্যাক, ককেশিয়ান, হিসপ্যানিক, ওরিয়েন্টাল না আদার রেসেস আমি জানি, তাহলে আমি ক্রিয়াটিনিন ক্যালকুলেট করতে পারবো। I want you people to look up the net yourself and tell me the name of these two calculations যেটা থেকে আমরা GFR ক্যালকুলেট করতে পারবো, ঠিক আছে? প্লিজ নোট দ্যাট ডাউন, দ্যাটস one homework that you're going to do. So এই কোয়েশ্চেনটা তোমাদের দুটো হোমওয়ার্ক দিলাম। একটা হচ্ছে you have to tell me the processes যেটা থেকে বডিতে ক্রিয়াটিনিন, the metabolic process which produces creatinine in the body, one. সেকেন্ড হচ্ছে জিএফআর ক্যালকুলেট করার জন্য কি দুটো বেসিক ইকুয়েশন আছে, সবাই বুঝতে পেরেছে? I need some response, guys. সবাই বুঝতে পেরেছে? হ্যাঁ, না? Okay, continue. আচ্ছা, now moving on to the next question. A 37-year-old female patient is... Oh, Ankita is here. Okay, thank you so much, Ankita. Ankita, then are you recording the screen? Then I would stop screen recording.
Yes, ma'am, I have already started recording it.
Are you feeling a little better?
Okay.
Don't stress yourself. If you are not feeling better, don't stress yourself.
Okay, ma'am.
But if you're continuing with the screen recording, just leave it at the screen recording and go back to your bed. I really don't want you to exhaust yourself, Maria.
Ma'am, it's being recorded.
Okay, then you just leave it. I'm stopping my screen recording, but you need not participate in today's discussion. You can just go through it once. Since it's being recorded, you can listen to it later on. And if I require something from you and Sweta, I would say it out, and later on you two can make a note of it. Okay?
Sure, ma'am. Thank you.
Thank you, Ankita. Thank you so very much. Okay, Ankita has already very kindly typed out the question for us. I would still reread it once. A 37-year-old female patient is diagnosed with cholelithiasis with stones in the gallbladder duct. The patient's blood shows blood glucose PP 270, fasting 190, bilirubin 5 mg per deciliter. We do. It has not been mentioned whether this is conjugated or unconjugated bilirubin. She's posted for OT but cannot be operated because of her uncontrolled sugar level. She's grossly underweight. Would you manage the case? A very, very interesting case which you might often come across. So basically, what are the things we are dealing with? It has lithiasis in where the GD duct. The patient is showing
Ma'am, the
hyperglycemia. Okay.
hyperglycemia and obstructive jaundice. That is the surgical jaundice
Tell
for
me
GD.
something. Why is who is this one who is answering? Shukriyo. Can anybody else other than Shukriyo and Kamran state why Shukriyo has said obstructive jaundice? Is absolutely correct. This is obstructive jaundice. Despite it being mentioned, this is clearly obstructive jaundice. Can somebody else says? Shukriyo has clearly guided us in the right direction and said it is obstructive jaundice. Yes, the bilirubin is high. That is the reason it is jaundice or icterus basically. But why and the icterus is present because of obstructive jaundice. Yes, gallbladder stone. The patient has gallbladder stone. Why did Shukriyo mention that this is probably conjugated bilirubin and not unconjugated bilirubin? I'm sure that is how he drove to the conclusion that this is obstructive jaundice. Somebody other than Shukriyo and Kamran, please. If nobody. Okay, nobody seems to be having the answer. Shukriyo, can you please give us the rest of the answer then? Are you there,
jaundice, obstructive jaundice বলতে চাইছি ম্যাম, obstructive jaundice is because the bilirubin level is high and the GB stone is performed in here common bile duct. So
এক্স্যাক্টলি জিবি স্টোনটা কমন বাইল ডাক্টে আছে যে কারণে খুব সম্ভবত এখানে কনজুগেশন হচ্ছে যে বিলিরুবিনটা হচ্ছে ফর কিন্তু বেরোতে মানে ঠিক জায়গায় আসছে না ব্লাড স্ট্রিমে চলে যাচ্ছে
আসতে পারছে না, এক্স্যাক্টলি ম্যাম।
এর জন্য এটা কনজুগেটেড বিলিরুবিন লেভেল এবং এটা অবস্ট্রাকটিভ জন্ডিস। সুপ্রিয় যেটা বলার চেষ্টা করছে সেটা সবাই বুঝতে পেরেছে? ক্লিয়ার টু এভরিবডি? If it's clear to everybody, then I want somebody other than Shukriyo ba Kamran to repeat what has been discussed so far. Not Shukriyo or Kamran. You can unmute yourself and say it aloud. Tanya wants it repeated at Kripa, so I want somebody other than Shukriyo and Kamran to explain what Shukriyo just explained to us.
Ma'am, can I say something?
Please.
Ma'am, since bilirubin is high and it's a case of polylithiasis, but if it is a case, if the stone is impacted in common bile duct, then it has to be choledocholithiasis.
Stone be impacted in common bile duct.
Then it's choledocholithiasis, ma'am. But
It is polylithiasis, yes, and the stone is in the common bile duct. That is the reason why we have conjugated bilirubin which is high.
ma'am, I just wanted to know it's what is polylithiasis and what is the choledocholithiasis?
Yeah, it is choledocholithiasis. We are commonly calling it polylithiasis. It is choledocholithiasis.
That's the reason it's ma'am like conjugated. That's what.
It is polydocholithiasis because it is conjugated. The other way around, my dear.
Yes.
Okay, this is very nicely explained the entire thing to us. It is polydocholithiasis because it is conjugated bilirubin and the stone is in the common bile duct. And if you remember, I was talking about the most probable site is the ampulla of Vater. Am I clear so far? Now let's come to the other problem. Let's come to the problem that this patient is hyperglycemic, but she is grossly underweight and therefore she cannot undergo surgery. Do we really need to give her a diabetic diet? That is the next question that we have. The next most pertaining question for this is, would you suggest a diabetic diet to this patient? Anybody? Including Shukriyo and Kamran this time. Would you Yes, but high energy diet. You will just, how can you give a diabetic diet which is high energy, low carbohydrate? Which means you want to give a diabetic diet to this patient, right?
First of all, we have to rule out whether it is diabetic or not, because acute pancreatitis is the commonest complication of mild episode. So we have to rule out whether it is acute pancreatitis leading to diabetes
Exactly,
or whether it is
exactly.
epidiabetes.
Do we actually need diabetic diet for this patient? What would be
No, ma'am.
actually
No, ma'am.
this diabetes is happening?
The
So what do
diabetes
we do?
is
We do really need to think of
the diabetes is
happening because
pertaining
actually
because
diabetes,
the
because this is actually not diabetes. This is just Shukri, I'll just interrupt before you continue. First of all, this is not diabetes. This patient is hyperglycemia. This is what I want to first stress upon. Do not call it diabetes, people. This is hyperglycemia because, as Kamran very correctly said, one of the commonest involvement is that of the pancreas in an acute state. Shukri, you can continue now.
as because the hyperglycemic level, the patient is not diabetic patient. So we can manage it through the protein enriched food.
Firstly, what you need to manage is with, you have to manage the hyperglycemia with insulin. Let's not get into diet. Rather, the diet should be targeting towards correcting the underweight issues, whatever way is possible. The hyperglycemic condition can be managed with insulin. Basically, this hyperglycemic condition is probably because of the GB stone, which is leading to the pancreas getting inflamed in an which is leading to an acute pancreatic inflammation, which is causing this hyperglycemia. Okay, it is
Exactly,
basic.
ma'am.
I will safely assume that this patient is probably not diabetic, and the moment she undergoes her operation, uh, cole, mm,
Cholecystectomy.
not only cholecystectomy, there can be
Choledocholithotomy. Choledocholithotomy.
there has to be a cholecystectomy. So once that is done, this will patient will probably be completely freed from the hyperglycemic symptoms that she is currently facing. So basically, we need to get the patient prepared for OT. We need to get it stabilized for OT. So as Shukri was mentioning, and somebody else had mentioned, a high energy, high nutrient diet is what the patient requires. Glycemic control can be done through insulin levels. We just need to, balance it out with the insulin level, maybe for 3 or 4 days or maybe a week, so that the patient can be posted for OT. So what we learn from here is, we learn that you first assess the acute condition and then you think about the chronic condition. So what is the acute condition out here? It is basically the GB stone, which is causing everything else, and he is not being able to be operated because of that. So you don't control the sugar levels with diet, because you need to address the underweight conditions. The uncontrolled sugar will be taken care of through insulin. That is an acute management. Okay, dietary modification for diabetes is basically a chronic management. 2 days of dietary intervention is not going to control diabetes. Rather, in a case of hypoglycemia, you can give something like, dextrose monohydrate. You can just write that down, dextrose monohydrate. These kinds of things can be given to an acute hypoglycemic patient to bring up the sugar level. Dextrose monohydrate. Okay, there are products like G75. If you Google out dextrose monohydrate, you find they are often used for GTT or glucose tolerance test in gestational diabetes. But trust me, dextrose monohydrate need not be restricted to only gestational diabetes. It can be freely used for other sudden recurrent hypoglycemia in various patients. Can somebody tell me, if there is continuous recurrent hypoglycemia, what can be the next disastrous uh, element that can be formed in the body?
Shock. Renal shock.
Okay, renal acidosis can happen, but what is the other thing can be indicative
Ketoacidosis.
of worsening? If there is
Hypo,
recurrent hypoglycemia, the patient slips.
Ketoacidosis.
ketoacidosis, hypovolemic shock,
Rectal hypoglycemia, the patient can slip into a coma.
diabetic coma,
Ketone
diabetic
body is
ketoacidosis,
being formed.
ketoacidosis, ketosis,
Glycopenia. Ketosis, not neuroglycopenia. It's the ketoacidosis that is the neck, and the formation of the ketone bodies. If this once go to your brain, there will be a ketotic coma if there is recurrent hypoglycemia in a patient, or there is a severe hypoglycemia in the patient. Ketoacidosis. Yes, ketosis, ketoacidosis. So this is basically the next diet plan. Are you completely thorough with whatever being trying to discuss? Anybody has any confusion?
no ma'am.
Mostly, I'm very sorry I got disconnected. Glucose level, पूजा की लिखिए glucose level আমরা ওইটাতেই অসুবিধা হচ্ছিল এই hypoglycemia থেকে দেখা যাচ্ছে see Pooja has if you go to the message section, Pooja has written it down very nicely. Glucose level the fall করলে body fat burn করতে শুরু করে for energy, where the moment body fat starts getting burned for energy, there are production of ketone bodies. Okay. Thank you, Pooja, for stating it so nicely for us. I believe যারা বুঝতে পারলো, they can all just read what Pooja has kindly texted for us. Okay? You're welcome, Pooja. Actually, this is how a group discussion should be happening. Everybody should be contributing. That is the way we get our doubts clear. That is the way we put in our thoughts. We can share it with everyone, and that is the way we all get a low card exchange, isn't it? There's no point in me just talking around, talking away, and you just, putting your phones on and just leaving it and going around with your everyday chores. I'm very happy the way this discussion is being happening today. Everybody is contributing. That is extremely nice. And I just don't want Kamran, Shukyo, and Ruma, and now Pooja has come up. Only these 4 people. I would like to see contribution from everybody in this group. And just remember one thing, whatever these group discussions we are having would also be a part of your internal assessment for your internship. So please contribute. I am noting who all are participating and who aren't. So please try and contribute. It really doesn't matter whether you're right or wrong. It's your participation that matters. Okay? Basically needed vast knowledge about biochemistry. Thank you, Pooja, but একটা জিনিস সবাই মনে রাখবে, dietetics is basically based on 3 key subjects: biochemistry, physiology, and your medicine. Later on comes in your pharma and your patho, but প্রথমেই when you are approaching a dietary condition, think about the biochemical processes, think about the physiological processes, and then think about the disease processes. Directly medicine সেটা ভাবতে পারো, বা তুমি সেটার সঙ্গে pathology ভাবতে পারো, ঠিক আছে? There will be a pathology involved, pathophysiology involved. So it is basically biochemistry টা মানে কি metabolism involved হচ্ছে, কি pathophysiology আছে patients দের, এরপরে your microbiology comes in and the rest of your subjects come in, but এটাই করবে. So yes, thank you Pooja, and also সবাইকে বলছি প্লিজ সবাই যদি না কেউ ভুলে গিয়ে থাকিস, go back to your basic physiology books, go back to your basic biochemistry books, যেগুলো basic cycles, basic hemodynamics কি করে মেইনটেইন করা হয় পেশেন্টদের, এগুলো কিন্তু প্লিজ আরেকবার করে, ইনফ্যাক্ট these are things which are very volatile, so পড়তে থাকবি, like keep going through it every maybe 3 months or 6 months. Just quick একটা ready reckoner, কোনো handbooks কিনে রাখবি নিজের কাছে, নিজের চেম্বারে, so that মাঝে মাঝে free time you go through it. That is because see we all tend to forget. So আমি রোজ পড়াচ্ছি বলে হয়তো আমার মনে আছে, তুমি নতুন পড়ছো বলে তোমার এখনো 3 বছর আগে যেটা পড়েছো ভুলে যাচ্ছ, বাট ওয়ান্স ইউ আর ইন প্র্যাকটিস না, এটা সবাই করবে, ঠিক আছে? Buy handbooks, ছোট ছোট handbooks of biochemistry, physiology, medicine. Medicine জন্য you don't need to open your Davidsons and Harrisons. Buy a Merck manual, or buy an Oxford handbook of medicine. Good enough. ওটার থেকে কুইক রেকমেন্ড হিসেবে দেখে নিন। ইনফ্যাক্ট ডেভিডসন হ্যারিসন, মানে ডেভিডসন তো তাও ঠিক আছে, হ্যারিসন করলে ফট করে ঘেটে যেতে পারো, হ্যারিসন রোজ রোজ পড়ার দরকার নেই। একটা অক্সফোর্ড হ্যান্ডবুক অফ মেডিসিন কিনে নাও, বা একটা মার্ক ম্যানুয়াল কিনে নাও, ওটা থেকে কুইকলি দেখে নিয়ে যাচ্ছে এই ডিজিজটা কি আছে, এটা কি 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 কোন কোন প্রগনোসিস আছে ইত্যাদি ইত্যাদি। সবাই বুঝলেন? Okay, see, Kamran here has said that it's neuroglycopenia that causes the coma rather than ketone bodies. No, it is the ketone bodies first and then neuroglycopenia. Get your clarification on that. Okay, Kamran? deficiency to the glucose to the brain cell, yes, but it is the deficiency to the brain cells. When that happens, the brain starts consuming ketone bodies. That is what leads to the coma. Get your chain of events corrected. You are just wavering a little. Tahale, I guess we are completely done with the second question. I am going forward to of the day. Shabar, is that an affirmative from everyone? That can we go ahead to the next third question of the day? Okay, thank you, Shobhit. 44-year-old man with a history of peptic ulcer surgery presents with palpitation, tachycardia, lightheadedness, diaphoresis after meal. Symptom begins 30 minutes after eating. আমি আজকে এই কোয়েশ্চেনটা ডিসকাস করব না, আজকে তোমরা আমাকে এই কোয়েশ্চেনের উত্তরটা বলবে। কেন? বিকজ যদি তোমরা মন দিয়ে ক্লাস শুনে থাকো, the last class on Thursday, we had clearly discussed this. This is more or less a repetitive question. What is happening to the patients? আজকে আমি একদম বলবো না। I want the answers from you, and please, Kamran and Shukriyo and Yuma, only answer if nobody else is being able to come up with. I want the other people, those silent, muted people in this class, to come up and talk. এই পেশেন্টের কি হচ্ছে? Palpitation, tachycardia, lightheadedness, and diaphoresis after meal. প্রথম কোয়েশ্চেন, ডায়াফোরেসিসটা কি করে বোঝা যায়? আগের দিন একজন রুমা আই বিলিভ হ্যাড ক্লিয়ারলি এক্সপ্লেইনড ডায়াফোরেসিস কি করে বোঝা যায়, এন্ড তারপরে we had discussed এই পেশেন্টটা কি হচ্ছে। আগের দিনের একটা কোয়েশ্চেনে আমরা বলেছিলাম which is a long standing problem, যদি কারোর অনেক দিন ডায়াবেটিস থাকে তাহলে তার হয়। Come on, এই কোয়েশ্চেনটা আজকে আমি উত্তর দেব না, and I believe Kamran, Shukriyo and probably Ruma is waiting for their chance to answer, but
কিছু খাবার পর মানে একসাথে অনেক মানে কিছুটা খেলে একসাথে খাবারগুলো ডাম্পিং হয়ে যায়।
এক্স্যাক্টলি, তাহলে কি বলে সেটাকে?
পিচকারির মতো ঢুকে যায়, মানে
ডাম্পিং সিনড্রোম বা ডায়াফোরেসিস কি করে বোঝা যায়? যে প্লিজ সবাই মিলে মিউট আনমিউট করো না। সুপ্রিয়া বদলেছ, পল্লবী ইউ ওয়ান্ট টু আনসার, আনমিউট ইয়োরসেলফ এন্ড আনসার। নো ফাংশন, স্বেটিং, ঠিক আছে, অ্যাবনর্মাল স্বেটিং, হ্যাঁ একদম নিশ্চয়ই হয়, স্বেটিং হয়, কিন্তু ওই যে কেস বলার চেষ্টা করছিল ডায়াফোরেসিস, সেটা স্বেটিং এর থেকেও, স্বেটিং এর সঙ্গে মেইনলি কি কি সাউন্ডস আমরা পিক আপ করি?
Flashing sound, flashing.
Very good, succussion splash. তাহলে পেশেন্টটা ডাম্পিং হচ্ছে, তাই তো? সবাই এগ্রি করছে তো, পেশেন্টটা ডাম্পিং হচ্ছে। তাহলে আমরা কি দেখতে পেলাম? পেপটিক আলসার সার্জারি যখন হয় তখন না পেটের যে জায়গাটাতে অনেক দিন আলসারাল ড্যামেজ হয়ে আছে সেই জায়গাটা কেটে বাদ দিয়ে দেওয়া হয়, রাইট? তো তার মানে কি হচ্ছে? সেখানেও তোমার শর্টেনিং অফ দ্য জিআই ট্র্যাক্ট হচ্ছে। I hope you all agree with me. GI surgery তে, পেপটিক আলসার সার্জারিতে অনেক সময় একটা portion of your GI tract is removed, a part of your stomach is removed. তো সেখানেও কি হচ্ছে? শর্টেনিং হয়ে যাচ্ছে of the tract। তাতে কি হচ্ছে? যদি ধরো তোমার antrum is removed, তাহলে antrum এর কাজটা হবে না, তোমাদের পাইলোরিক সাইডটা থেকে রিমুভ। যদি তোমার ধরো ফান্ডাসের ওখানটা রিমুভ হয়ে যাচ্ছে, তাহলে কি হবে? তাড়াতাড়ি খাবারটা নেমে যাবে, তাই তো? তাহলে either way transit time of the food is increasing while it is in the stomach. স্টমাকে যতক্ষণ থাকা উচিত ততক্ষণ খাবারটা থাকতে পারছে না। আর আমরা জানি যে স্টমাকে is the main time where the digestion of the various nutrients of the food starts, তাই তো?
Exactly, ma'am.
Therefore আমরা জানি আমরা যে ইন্টেস্টাইনে কোন পোরশন অবধি ডাইজেশন হয়, তারপরে শুধুই অ্যাবজর্পশন হয়?
First part of jejunum. First part of jejunum.
Yes, first part কেউ শুক্রিয়া প্লিজ উত্তর দিও না। let the non medical people speak up, আমরা জানো, আমি জানি, তো তোমরা একটু ওদেরও পার্টিসিপেট করতে দাও, তোমরা না পারলে কেউ তখন উত্তর দিও। এবার শুক্রিয়ার কামরান তো উত্তর দিচ্ছে, বাকিরা একটু চেষ্টা করো। জেজুলাম ফ্রম villi জেজুলাম ফ্রম villi অ্যাবজর্পশনের মানেটা কি জানাবে? সুপ্রিয় একটু উত্তর দিয়েছে, তো একজন কেউ খালি ফার্স্ট পার্টের নামটা বলো, না বললে সুপ্রিয়া আমি শিওর একটু পরে সুপ্রিয়া বা কামরান বলবে, বাট কেউ ফার্স্ট পার্টের নামটা বলো। ইলিয়াম ইজ দ্য ফার্স্ট পার্ট, মৌসুমী প্রচন্ড বকুনি খাবে। বেসিক ফিজিওলজি, বেসিক অ্যানাটমি ভুলে যাচ্ছ তুমি। ডিওডেনাম, থ্যাংক গড সুপ্রিয়া, নো নট জেজুলাম, ডিওডেনাম। ডিওডেনাম অব্দি কিছু ডাইজেশন হতে পারে, জেজুলাম অনওয়ার্ডস শুধুই অ্যাবজর্পশন হয়। ঠিক আছে, যে কারণে আমরা যখন জেজুনোস্টমি করে থাকি কোনো পেশেন্টে, তখন খাবারটা হ্যাজ টু বি ইন যতটা মোনোমেরিক ফর্ম ততটা পসিবল। আমরা যদি গ্যাস্ট্রেক্টমি করি বা ডিওডেনোস্টমি করি, নরমালি ডিওডেনোস্টমি করা হয় না, ইটস নরমালি গ্যাস্ট্রেক্টমি, ইসোফেজাস্টমি, তারপরে গ্যাস্ট্রেক্টমি বা জেজুনোস্টমি।
গ্যাস্ট্রোজেজুনোস্টমি।
Gastrojejunostomy is basically between you are entering through the gastrum and ending the pipe in jejunum. ওটার থেকে আজকাল more convenient is jejunostomy. If you look into the hospital scenario today, the surgeons prefer jejunostomy over gastrojejunostomy. ঠিক আছে, তো যদি jejunostomy করা থাকে তাহলে খাবারটা কিন্তু তোমাকে মেইনলি দিতে হবে যতটা সম্ভব ইন মোনোমেরিক ফর্ম। আর ইসোফেজাস্টমি বা গ্যাস্ট্রেক্টমি যদি হয়ে থাকে তাহলে আমি নর্মাল খাবার দিতে পারি, কারণ ওখানে নর্মাল ডাইজেশন হচ্ছে, ডাইজেশন প্রসেসেস আর হ্যাপেনিং। কিন্তু এখানে তো পেপটিক আলসার সার্জারি যদি খানিকটা স্টমাকের অংশই কেটে বাকি আছে, therefore there will be quick transit of the food. So this diet is going to be absolutely mimicking for what of the diet of question number 5 that we had discussed the day before. Everybody agreeing to it? How কিছু question আছে, কেউ কিছু কোশ্চেনে কিছু অ্যাড করতে চায়? সুপ্রিয়, কামরান, রোমা, any of you want to add anything?
No, ma'am.
Kamran, Ruma, anybody wishes to add anything to this? আচ্ছা, so I believe না তাহলে আজকে we did 3 questions. তোমাদের বোধহয় কামিং বৃহস্পতিবারের মধ্যে শ্বেতা ম্যামকে কোয়েশ্চেন, বাকি দিনের কোয়েশ্চেন্স গুলো পাঠিয়ে দেওয়ার কথা, নাকি রোববার আজকের মধ্যে পাঠানোর কথা ছিল, রাইট? তোমরা কি পাঠিয়ে দিয়েছো সবাই তোমাদের আনসারস গুলো, ডায়েট প্ল্যানস গুলো?
Ma'am, first 3 questions I have sent to mail ID through Shweta ma'am. 1, 2, and 3. And rest 4, 5, 6 are pending today.
Okay, Kamran has sent, Shukriyo has sent. What about the others? First 3 questions Megha has sent, very good.
I have
What about
also
the
sent,
others?
ma'am.
Pooja has sent, Shobhik has sent, very good.
Yes, ma'am.
Shobhik,
Ma'am, I also have sent.
Shobhik, I just had a, yeah, are you also a doctor or?
I'm a pharmacist and medical in charge in a unit.
Okay, okay, great.
I used to diagnose and give primary treatment.
Okay, very good.
Ma'am, one point is maybe added. The person is presenting sinus tachycardia. That is
I believe সবাই বুঝবে এখানে, if Kanchan does not understand, I'll translate.
tachycardia. Tachycardia means sinus tachycardia, which is mostly seen in ECG, echocardiography. Sinus tachycardia common cause of peptic ulcer is TIBC, total iron binding capacity is diminished for, so that sinus tachycardia also seen in case of peptic ulcer patient.
Have you all noted this point that Shukriya wanted to add? সবাই বুঝতে পেরেছো পয়েন্টটা? What Shukriya has been trying to say out here is, আমাদের আগের দিন, if you remember, we were talking about the amino acid pools. সেখানে we were talking about certain carrier proteins. এবার সেই carrier প্রোটিনের সঙ্গে যখন গিয়ে আয়রনটা, মানে এই টোটাল আয়রন বাইন্ডিং ক্যাপাসিটি বডি, সেটা অনেক সময় নির্ভর করে হচ্ছে কতগুলো ক্যারিয়ার প্রোটিন আছে আর সেগুলোর কোন স্টেটে ফিল্ড আছে। যদি ধরো তোমার কাছে কম নাম্বার অফ ক্যারিয়ার প্রোটিন career মানে ধরো career protein is like a bag, যদি তোমার কাছে কম নাম্বার অফ ব্যাগ থাকে তাহলে তুমি কম জিনিস বয়ে নিয়ে যেতে পারবে, তাহলে তোমার সেই হিসেবে ভাবতে পারো তোমার যখন ব্যাগগুলো খালি থাকবে তখন তোমার টোটাল আয়রন বাইন্ডিং ক্যাপাসিটিটা বেড়ে যাবে, ঠিক আছে। যখন আমাদের কি হয় শরীরের ভেতরে, যদি তোমার অ্যাডিকুয়েট আয়রন না দেওয়া হয় বডিতে বা যদি অ্যাডিকুয়েট প্রোটিনস না থাকে বডিতে, তখন আমরা অনেক সময় দেখি টোটাল আয়রন বাইন্ডিং ক্যাপাসিটিটা বেড়ে যাচ্ছে, ঠিক আছে, কমে না কিন্তু বেড়ে যায়। মনে রেখো, খালি ব্যাগ তো তোমার জিনিস একটা জায়গা থেকে আরেকটা জায়গায় নিয়ে যেতে হবে, তো তুমি তো ব্যাগটার মধ্যে ভরতে চাইবে, তাই না? ওই ব্যাগটার মধ্যে ভরাটাকে কল্পনা করে নাও ইজ ইয়োর টোটাল আয়রন বাইন্ডিং ক্যাপাসিটি। বেসিক্যালি এই টপিকের অফ নিউক্লিওজেস, লেট মি গিভ ইউ আ স্মল মানে এক্সপ্লেনেশন। আমরা যখন কখনো বলি পেশেন্টের অ্যানিমিয়া হয়েছে, সেটা কিন্তু বেসিক্যালি আমরা তিনটে স্টেজে দেখে থাকি, ঠিক আছে। প্রথম স্টেজে কিন্তু আমরা হিমোগ্লোবিন ডেফিসিয়েন্সিটা পাই না। যখন একটা পেশেন্টের হিমোগ্লোবিন ডেফিসিয়েন্সি হয়ে গেছে তার মানে তার ফ্র্যাঙ্ক অ্যানিমিয়া হয়ে গেছে। এবার ধরো ইন কেসেস লাইক স্পোর্টস মেডিসিন, এই সমস্ত জায়গায় বাই দ্য টাইম হিমোগ্লোবিন ডেপ্রিসিয়েশন ঘটে গেছে, তার মানে কিন্তু লটস অফ ড্যামেজ হ্যাজ বিন ডান। আমরা সেখানে সাবক্লিনিক্যাল ফর্মস অফ অ্যানিমিয়া গুলো দেখতে থাকি। সেখানে কি দেখা হয়, সেখানে না টোটাল আয়রন বাইন্ডিং ক্যাপাসিটি দেখা হয় এবং সেখানে সেরাম ফেরিটিন এবং সেরাম ট্রান্সফারিন লেভেল দেখা হয়। কেন সেরাম ফেরিটিন আর serum ferritin আর serum ferritin আর serum transferrin level কেন দেখা হয়? রিমেম্বার, ওরা কিন্তু will be indicative of your amino acid pool, ঠিক আছে। তো সেক্ষেত্রে তুমি কিন্তু তখনও কিন্তু হিমোগ্লোবিনটা কমেনি, কারণ সেটা তখনও ক্লিনিক্যাল ম্যানিফেস্টেশন অফ অ্যানিমিয়া অবধি যায়নি, এখানে সাব ক্লিনিক্যাল ম্যানিফেস্টেশন হয়ে আছে। সেখানে কিন্তু অনেক বেশি তাড়াতাড়ি পেশেন্টকে রিকভার করানো সম্ভব যদি আমরা সেই মুহূর্তে তার প্রোটিন ইনটেকটাকে বাড়িয়ে বা সামহাও তার বডিতে অ্যামাইনো অ্যাসিড পুলটাকে বাড়িয়ে দিতে পারি, ঠিক আছে। সবার মনে থাকবে তো? টোটাল আয়রন বাইন্ডিং ক্যাপাসিটি বেড়ে যায় সেকেন্ড স্টেজে। ফার্স্ট স্টেজে কি হয়, টোটাল ফেরিটিন আর টোটাল ট্রান্সফারিন লেভেল গুলো কমতে থাকে। সেকেন্ড স্টেজে টোটাল আয়রন বাইন্ডিং ক্যাপাসিটিটা বেড়ে যায়। তারপরে গিয়ে কিন্তু ফাইনালি বেশ কিছুদিন এটা হওয়ার পরে হিমোগ্লোবিন লেভেলটা পড়ে। এটা সবার কাছে ক্লিয়ার? Is everybody clear with this particular thought?
Clear, ma'am, clear.
Kanchan, have you understood? Yeah, I know you. Kanchan, have you understood? Do you want me to repeat it in English? First point, which one? Which is the first point? Can you? যেকোনো first point বলবে সে please ferritin. Ferritin transferrin হচ্ছে তোমার career and ইয়ে protein. Transferrin is your career protein while ferritin is your storage protein. ঠিক আছে? এগুলো সমস্ত অ্যামাইনো অ্যাসিডস দিয়ে বিল্ড করা হয়। যে এখানে বলে ফার্স্ট পয়েন্টটা বুঝলাম না, what first point you want to explain? Just unmute yourself.
হ্যালো ম্যাম, বলছি ফেরিটিন আর ট্রান্সফারিনের ফাংশনটা একবার বলুন, মানে ওটা কিভাবে ইন্ডিকেট করে যে আমাদের
তোমার বডিতে অ্যাপোফেরিটিন আর অ্যাপোট্রান্সফারিন হিসেবে থাকে। তো ফেরিটিন হচ্ছে তোমার স্টোরেজ প্রোটিন, সে আয়রনকে স্টোর করতে পারে। যে মুহূর্তে অ্যাপোট্রান্সফারিনের সঙ্গে এসে আয়রন বাইন্ড করে তখন সেটা ট্রান্সফারিনে অ্যাপোন আওয়ারটা সরে যায়, ইট বিকামস ট্রান্সফারিন। আর যে মুহূর্তে অ্যাপোফেরিটিনের মধ্যে এসে আয়রন স্টোর হয় সেটা সামনে থেকে অ্যাপোটা সরে গিয়ে বিকামস ফেরিটিন। বোঝা গেছে? অ্যাপোট্রান্সফারিন বিকামস ট্রান্সফারিন, মানে অ্যাপোট্রান্সফারিন হচ্ছে তোমার খালি ব্যাগ, তার মধ্যে আয়রন ঢুকলে সে বিকামস ট্রান্সফারিন। সে তখন মেমব্রেনের অ্যাক্রসে ওই আয়রনটাকে নিয়ে যায়, নিয়ে গিয়ে কার মধ্যে ডিপোজিট করে দেয়, তখন দাঁড়িয়ে আছে হচ্ছে অ্যাপোফেরিটিন। অ্যাপোফেরিটিনের মধ্যে সে গিয়ে তার যে ম্যাটেরিয়ালটা সে ক্যারি করে নিয়ে যাচ্ছে আয়রন, সেটাকে ট্রান্সফার করে জমিয়ে রাখে, তখন অ্যাপোফেরিটিন বিকামস ফেরিটিন। ক্লিয়ার?
হ্যাঁ, ইয়েস ম্যাম।
Okay. So is the 3 levels of anemia also clear to everybody?
Yes ma'am.
Yes, ma'am. Yes, ma'am.
Yes. Thank you, Supriya, for bringing it up.
Thank you, ma'am.
Ma'am, I would like to add one more thing.
Yes, Kamla.
Ma'am, I would
Yes,
like to add foods that can increase serotonin level. Because in this patient we are saying that there is light headache and tachycardia. So actually, light headache and tachycardia is actually serotonin induced.
one minute, Kamran. It is light-headedness, not light headache. Please read the headedness, matha ঘুরছে. Serotonin will not help with your matha ঘোরা. That's not headache. I believe you misread it. It's light-headedness, which means you're feeling light-headed. You're having a reading sensation. Serotonin will not. Not exactly frank vertigo, but it will be like lightheadedness, something that feels like a vertigo, but not a frank vertigo per se. Okay. Serotonin helps with your headache. That can help with your sleep. Serotonin, melatonin, the derivative. By the way, other than Shupio Kamran and the pharmacist we have here, serotonin chemical নামটা কি? Biochemical name of serotonin কি? খুব commonly এটা পাবে question এ one word answers যেগুলো আসে। যদি কেউ নেটের জন্য প্রিপেয়ার করছো বা প্ল্যান টু প্রিপেয়ার অন নেট, এই কোয়েশ্চেনটা খুব পাবে। Can somebody tell us? কেউ প্রেসার অ্যামিনের নাম শুনেছে?
Yes, ma'am. Yes,
প্রেসার
ma'am.
অ্যামিন, প্রেসার অ্যামিন নয়, প্রেসার অ্যামিন নাম শুনেছো?
Yes, ma'am.
সো 5 হাইড্রক্সিট্রিপ্টোফ্যানের অন্য নাম কি? What is the other name for 5 hydroxytryptophan? Come on guys, Google. আমি উত্তরটা বলবো না। 5 hydroxytryptophan, 5 hydroxytryptamine, তার other name কি? Common name কি? 5 hydroxytryptophan becomes 5 hydroxytryptamine. তার other nameটা কি? গুগল করো, চলো ফাস্ট এভরিবডি। এটা মনে রেখো, যদি তোমরা নেক্সট দেবে ভবিষ্যতে বা কিছু কোয়েশ্চেন কিন্তু খুব আসে। ইটস আ ভেরি কমন কোয়েশ্চেন। আর এখন আসে আরো বেশি বিকজ এটা নিয়ে প্রচুর এখন দ্যাট ইজ লাইক দ্য অল্টারনেটিভ থিং ফর স্লিপ মেডিকেশন other than antidepressant and things like that. This is basically the common alternative which is being suggested by the world for sleep medication. নামটা এক্ষুনি কেউ একজন বলে দিয়েছিল কি? হ্যাঁ, সেরোটোনিন, এক্স্যাক্টলি। সবার মনে থাকবে তো? এটা কিন্তু একটা ভীষণ কমন কোয়েশ্চেন। Yes, Megha is right. ঠিক আছে, ওকে, দেন আই বিলিভ তোমাদের আর আজকে নিয়ে কোনো কোয়েশ্চেন নেই। যদি কোনো কোয়েশ্চেন না থাকে দেন ওয়ান বাই ওয়ান জাস্ট স্টার্ট লিভিং দ্য গ্রুপ সো দ্যাট আই নো দ্যাট ইউ আর কমপ্লিটলি ক্লিয়ার উইথ টুডেজ ক্লাস।
Thank you, ma'am, for your
Thank
great
you,
class.
Shruti.
Okay.
Thank you everybody for all your inputs. We want these to be interactive classes. Next time you সবাই চেষ্টা করবে inputs দিতে।
Ma'am, what I was saying that serotonin is because hello.
Yes, Kamran, say.
Ma'am, I was saying that tachycardia, lightheadedness, diaphoresis, it all related to 5-HT. That is why I was suggesting to add.
No, Kamran, in this case, serotonin is not going to be of any help. This entire thing is happening due to dumping, and serotonin will not help you with dumping. You can understand you are trying to deal with it in the homeopathy kind of way where you go by the symptoms rather than by the rather than the disease itself. I'm completely on agreeing with you on that. But the thing is here, this is a clear case of dumping, so you actually cannot treat by the symptoms alone, which of course is the way you deal in homeopathy. I know that. But ekhane you won't be able. Serotonin really won't be able to help you much. So বাকিটা if you have nothing more to say something. হ্যাঁ, বলো।
Ma'am, from past 4 days, I'm not at all well. I've been down with fever. And yes, ma'am. So I cannot really get up from my bed. And so tomorrow is college, as Shweta ma'am informed. but I am going for the COVID test only.
Don't worry about your attendance. No, you don't worry about your attendance. Don't come to class. Please and get yourself checked for COVID.
Yes, ma'am.
And don't come till you feel better. Yeah, you are. Please don't worry about your attendance. It will be given.
And ma'am, I could not complete the questions so by today because I'm feeling a better now.
Yes, we are all there to help you. Don't worry. Take care of your health first. I'll
Thank
just
you.
request you to keep an isolation in your home. Don't make sure that nobody else in your house is also coming in close contact with you.
Yes, ma'am, I'm in a separate room.
Yeah. Okay, Tanya.
Thank you, ma'am.
Yeah, you're welcome. You could all